Hi there. For those of you who have listened to some of the previous talks during this International Alzheimer's Awareness Month, you would have noticed that I refer to the so-called, as if I would go so-called, symptoms of dementia. Now, the reason why I say so-called, or put them in inverted commas, is that it is quite a controversial thing, the behavior that is attributed to dementia. Now, in medical terms, it's referred to as behavioral and psychological symptoms of dementia. It's even got its own acronym, BPSD. And the definition is the term behavioral and psychological symptoms of dementia refers to the spectrum of non-cognitive and non-neurological symptoms of dementia, such as agitation, aggression, psychosis, depression, and apathy. At least 80% of people with dementia experience BPSD. Now, I find that a very difficult concept to come to terms with. People living with dementia somehow are not allowed to express their emotions or their frustrations. And if they do, it is related straight back to their dementia. What about ordinary frustration? What happens to sadness? These are so-called normal emotions, but the minute they are shown by someone living with dementia, these become symptoms of dementia. I will tell you a little story that I experienced many years ago. There was a particular resident in an acute psychiatric clinic living with dementia. She was there for the psychiatrists to figure out her medication. I spoke to the nurse, the two psychiatrists, psychologists, caregivers, occupational therapist, physiotherapist, after observing this particular woman for a whole day. During the clinical rounds, I was informed that Mrs. Cohen shows very aggressive behavior, especially at breakfast. And since she's been in the clinic, she's broken about 6 plates of food during breakfast, where she would literally take her plate of food and smash it on the ground. Now, Mrs. Cohen had quite advanced dementia, and she was not able to communicate verbally any longer. However, she communicated very clearly that she was angry and that she did not want this plate of food in front of her, and that she was so angry that she actually took it and smashed it on the floor. Now, very interestingly, during the clinical rounds with all the experts around the table, the case of Mrs. Cohen was discussed at length. After the psychiatrist listened to all the different opinions, he looked at her records, saw frontal lobe dementia, and said maybe we should up the Risperdal. After the clinical rounds, we had a conversation, and I said to the psychiatrist that I was really intrigued by Mrs. Cohen's behavior, and if they knew anything more about her. And they said, well, nothing other than that she's living with dementia, she's in her 80s, and she really is aggressive. I then asked the psychiatrist, what do you serve for breakfast at this clinic? And he said, well, it's a very upmarket clinic. They have bacon, egg, sausage, mushroom, everything every morning for breakfast. And I said, bacon? Is there a possibility that Mrs. Cohen could be Jewish and that in all her life she's never had a dead smoked pig on her plate? Well, that didn't go down very well, especially after I asked the psychiatrist, I wonder who needs the medication, the employees or Mrs. Cohen. It was very clear that no one in the clinic made an effort to get to know Mrs. Cohen. Never mind the fact that her surname should indicate that she's Jewish, she might be Orthodox Jewish, and that her anger had nothing to do with her dementia, but everything to do with the fact that she was appalled by the fact that there was bacon on her breakfast plate. People living with dementia react like all of us react. They become angry, they become frustrated, they become sad, they become irritated, and they will respond accordingly. Can you imagine living with dementia? Can you imagine living with memory loss and cognitive impairment and the world treating you as if you are an imbecile? How much more you will react to the way that you are being treated. Every behavioral action of someone living with dementia is a need to communicate something. We, as people who care for people living with dementia, should become like ethnographers. We should really, really try and figure out, who is this person? Where do they come from? What are their likes? What are their dislikes? Tom Kitwood talked about the things that would uplift people or the things that would subdue them. I know that if I am in an environment where music is played all the time, I would certainly show a very distressed reaction. If I was in a place that is extremely noisy, I would show a distressed reaction. If I was given rooibos tea with lots of milk and sugar for breakfast, I would show a distressed reaction. And my distressed reaction, if you look at my personality profile, will most probably be that I will swear at you, tell you how bloody useless you are, and if you keep on doing it, I might even smack you. That's me. That's not because I'm living with dementia, but that is because I am an extrovert with a violent temper and quite expressive in what I like and what I don't like. That will not change if I live with dementia one day. We need to get to know the person behind the disease. We need to understand that emotions and reactions are not a result of a brain malfunction or of cognitive impairment, but a desperate need to communicate, a desperate need for people to understand who I am, what makes me angry, what makes me sad, and what will make me withdraw eventually. I don't think it is normal that people with dementia withdraw. What I think happens is that people simply give up. If the whole world does not understand you, if there is no space for you where you can be yourself, be amongst the things and the people that you like, then you will also withdraw. We need to read the signs of what people are trying to tell us or what they are trying to show us. And then we will think differently about the so-called symptoms of dementia.